Hello, doctor.
With Dr. Chandrika Anand.
Greetings to everyone. I am Dr. Chandrika Anand, a senior gynecologist, obstetrician practicing in Bangalore since 1998. Today, I just wanted to explain in detail the process of normal vaginal delivery. There are a lot of questions from our patients when they get ready for the labor on the D-day. They are worried about the pain, they are worried about the duration of the labor, whether they can eat on the day of labor, what preparations they have to do, and how long the process of labor will take. These are all some of the questions the patients ask. So I thought I'll start this video explaining briefly about different positions of the baby. What do we, whenever we talk to you about cervical dilatation, baby's head is not fixed, not descending, and she's getting good contractions. So what exactly it means? So I thought I'll brief you about it. Now, all of us know that the pregnancy lasts for 40 weeks from the last menstrual period. That is the first day of last menstrual period. The duration of pregnancy is around 40 weeks in humans. 37 weeks, it is called term pregnancy. Less than 37, it's called preterm pregnancy. 37 to 40 is term pregnancy. Beyond 40 is called post-term pregnancy. Almost up to 80% of women get spontaneous labor pains in the last 2 weeks of pregnancy. That's 38 to 40 weeks of pregnancy. They present to us with natural pains or pain abdomen. Around 10% of women, for various reasons, they deliver before 37 weeks. That's called preterm labor. And around 10% of women, they just don't get the pain even after the dates happen. The expected date of delivery is calculated from your last menstrual period, and then beyond the date also they do not get any signs of labor or they do not get any pains. So in such situations, it is called post-term pregnancy or post-dated pregnancy. That's around 10% of pregnancy. So how do you know that you have got into labor pains? Suppose your due date is around 15 days ahead or 1 week ahead. How do you know that you got labor pains? Labor pains, the signal starts from your brain. The brain decides that, okay, now we have to start the labor process. So there are different chemicals released in your body by different glands. Prostaglandins are important chemicals which are released during labor. So these prostaglandins will start creating cramps or muscular contractions of the uterus. Now if you see, this is the uterus. This is the uterus with a thick muscle. A very small uterus, non-pregnant uterus, the measurement is around 7 into 5 into 2.5 centimeters, a very tiny organ. The nature has designed in such a way that it will enlarge gradually over the pregnancy to accommodate a baby of 3 to 4 kgs along with the placenta. The placenta is the organ which supplies blood to the baby, that carrying all the nutrients and the oxygen. So along with the placenta and the water around the baby called amniotic fluid and the baby, together it may weigh around 5 to 6 kgs. So the uterus gradually balloons out, it becomes big, it is resilient, it is designed in such a way by nature that it holds the baby throughout the pregnancy. Now this is called the cervix or the neck of the uterus. Now this cervix remains closed throughout the pregnancy. The normal length of cervix is 2.5 to 4 centimeters and it remains closed throughout the pregnancy. When the delivery process starts, the collagen tissue around the cervix in the response to the different chemicals released gradually open up. Okay, that is called cervical dilatations. So if the cervix opens beforehand, suppose in the 3rd month, 4th month or 5th month, it's called cervical incompetence or a weak cervix. There the cervix opens up for no reason, and unfortunately the baby can get aborted spontaneously. So cervix is a very important organ of the uterus, normally 2.5 to 4 centimeters in length, keeps closed, tightly closed throughout pregnancy, and on the day of delivery, with the influence of the different chemicals, it opens up, causing cervical dilatation. So the baby, the uterus, such a big uterus, it contains a lot of muscle or the myometrium or the musculature. They start contracting under the influence of the chemicals and mainly the prostaglandins. That is the reason when we want to induce a delivery in a quiescent uterus, suppose if you have very high BP or a diabetes and you don't get the pains and we need to induce the labor, we use artificial prostaglandins or synthetic prostaglandins. We give you in the form of tablets or put a gel. So that is called induction of labor. So once these prostaglandins are released, the muscle starts contracting. So it is a quiet uterus, relaxed uterus. it will start contracting slowly. So how do you know you got labor pains? So you start getting period-like cramps either in the lower abdomen, upper abdomen, or in the back, radiating to the legs. Some girls just never have had periods pains. So for them, it can be just tightening of the uterus with a discomfort. So this pre-labor, when the body is getting ready for labor pains, it may start, the pains may last for a few seconds or 30 seconds, and then it may come once a day or twice a day or maybe 3-4 times. So that can be a pre-labor or just before labor what the pains start. So you need not panic. Once you get a little bit of cramps and back pain, so you can just take rest and drink lots of fluids. Just contact your doctor. Meanwhile, watch out the baby movement so that the baby is happy inside. So a progressive labor pain, this pain becoming more frequent, starts happening every 10 minutes, and the pain duration, instead of 10 seconds, 5 seconds, it starts lasting for more than 20-30 seconds, and the intensity of the pain also becomes more. So you get more frequent pains, more stronger pains, or more severe pains, and which is lasting for longer time. That is when it could be a labor pain, and that is when you have to talk to the doctor. And sometimes, because the cervix is all the time closed and there is a tissue or the cervical mucus plug which is there sitting throughout the pregnancy, once the cervix starts dilating, it may get discharged, causing a bloody stained discharge. Or some girls will come and tell us, I got some pain and I got some reddish tissue which got little bit of bleeding kind of tissue I got. That is nothing but we call it as a show or a mucus plug, a cervical mucus plug. Because it opens up, it comes out, calling the cervical mucus plug discharge, or it is called the show. So these are all the early signs of labor, that is contractions or painful contractions, back pain radiating to legs, and then discharge of a bloody mucus plug is called a show. So once you get these labor pains and once you get this, then you need to contact your doctor, and then you go to the doctor's hospital or the clinic. What does the doctor do? So the doctor will examine your BP, pulse, temperature, and she puts her hands over your abdomen to see whether the uterus is contracting. The uterus which is relaxed is felt relaxed by the hands. Once it is contracting, we can make out the contractions, and we count for how many seconds the contraction is lasting, and then it is intermittent contraction and relaxation which is happening. And then once the contraction is documented, then we check for the fetal heartbeat. We want to see how the baby is safe, whether the heartbeat is regular, what is the rate. So we can auscultate with a stethoscope or the fetal Doppler. Once we know that you are getting contractions, we want to know a lot of information. What is the lie of the fetus, whether the head is down or the legs are down, or whether it is a transverse lie. Now let us come to the lie of the fetus. Now the uterus is like this, ovoid in shape, and it is globular and ovoid in shape. So if the head is the presenting part, it is called the cephalic presentation. Cephalic means head, cephaloid means head. So cephalic presentation, the head presenting down, is the commonest presentation, happening up to 96%. 96% of pregnant women present with this cephalic presentation. Okay, why the head comes down? Because head is heavy, it is protected by the skull, whereas the breech or the bottom is not so heavy and is a soft tissue. So by weight or by gravity, the head comes down in 96% of women. So sometimes for different reasons, instead of the head, the breech comes down. We call the bottom or the buttocks as the breech. So the breech will come down, or it is a presenting part in almost 2.7% of pregnant women. Now, logically speaking, what are the causes for breech? Now we know the head is heavy. Why the head doesn't go in few cases? Because maybe there could be something already here, like a fibroid in the lower segment. There is a placenta sitting here, or if the uterus shape is not globular, it is a heart-shaped uterus. So that is when the head will try to go and sit in a place where it is comfortable and push the soft part of the breech down. This is called a breech presentation. This happens in around 2.7 per 100, or 27 women in 1000 pregnancy. So this is breech presentation. Very rarely, it's not very often, instead of the head or the breech, there's something called a transverse lie. Okay, so can you see here? Here the uterus is transversely stretched, the baby is transverse, the placenta is either here or here. So this is called transverse lie. Sometimes instead of the transverse lie, if the head is in an oblique situation, it's called an oblique lie. Now this is very rare. It happens in 3 out of 1000, that is 0.3% of pregnant women, there can be a transverse slide. Okay, this transverse slide can be very complicated because there is no way the baby can come out. The baby can't flex and the baby can't come out in a transverse slide. So here either the hand comes down or the shoulder comes down or the umbilical cord comes down. This can be a very risky pregnancy, but thankfully it is not very common. As I told you, the causes can be a deformity or a defective uterus, abnormal shape of the uterus, and then if there is a placenta down or if there is a tumor which is or a fibroid which is sitting in the lower segment, the transverse slide can happen. So transverse slide, there is no way the baby will deliver vaginally or normally. Okay. So now this is about the lie of the fetus. So the commonest, we are going to discuss only the commonest or the cephalic presentation. So in the cephalic presentation also, there can be different positions. There is the head, head in the front is called occipital anterior. This is the commonest position. Head in the posterior is called occipital posterior. This is next common. Okay, it can cause a little bit of difficult delivery. Sometimes instead of the head, the scalp, the face can be presenting or the brow can be presenting. So they are all called different positional changes. So that can have little difficult delivery compared to a normal vertex delivery or the cephalic presentation. Now, give me the pelvis. Okay, and the skull. So whenever we are explaining, whether the baby head is fixed or baby head is not fixed, we take in first timers or in the first primigravidas, we call them primigravidas. Here the baby's head gets engaged or fixed around 38 weeks because the abdominal muscles are tight, so it will push the baby's head down faster. Compared to the second or third delivery, the baby's head enters the pelvis a little later, maybe during the delivery process. So what do you mean by head is fixed? Now this is the pelvis. So the pelvis is almost like this, when a woman is standing, the pelvis is like that. So this is the pelvic brim. Okay, pelvic brim is the head has to enter here. That is called engagement or head fixing. People will ask whether whether the baby head is fixed. But that means that the baby has committed for a normal delivery. Okay, so this is the baby's skull if we take, and with the occipital anterior position. So now we are, yes. So the baby's head enter like this, that means it is fixed. The baby head is here. We can feel above your bone. Give me the baby. No, only the baby. So of course this is not proportional. So generally the baby is above the in the abdomen, it is palpable. So when the doctor come, hold this. So when we are examining over the abdomen, we can feel the baby's head. Baby's head is fixed or floating. We call it as floating because we can feel it. This is the pubic bone. Okay, when the baby's head enters the pelvic brim, it is fixed. When I put the hand over your abdomen and then when I try to move, I can't move. That is called fixed head or the engaged head. Okay, so the baby's head above, I can feel freely. It is a floating head. When the baby's head enters the pelvic brim, it is called a fixed head. Okay, so once it is fixed, we know that it can't turn like that and become a breech. Okay, when the baby's head is still here, it can turn like that or turn like this, depending on the contractions and depending on the uterus size and shape. Whereas once it enters, it is committed for a vaginal delivery. So that is a good sign. If you are a first time pregnant and if the doctor says that the head is fixed and the head has entered the pelvis, it is a good sign that the baby has committed for a normal vaginal delivery. So here now this is the pelvis, as I was saying. The baby's head has to pass through this canal. It is called a pelvic canal. So it is a birth canal. There's a birth canal. So what is normal labor? Normal delivery or a normal labor is the birth of the baby through the normal birth canal or the vaginal canal, with minimum discomfort to the mother, with minimum complications to the baby, with or without a episiotomy or a suture. Sometimes we cut the perineum, called the episiotomy suture, so that it opens up and it does not cause any tears. That is called normal delivery. Normal delivery is the delivery of the baby through the birth canal or the vaginal canal, with spontaneous onset of pains, with minimum complications to the mother and the baby of a full-term baby. The baby has to be a full-term baby. So normal delivery, in the normal delivery, as I was explaining, the baby, the commonest presentation is the cephalic presentation or the cephalic, the head down. and the baby is totally flexed. If you can notice that the baby's head is down and the legs and hands, everything is flexed, so that the baby will occupy minimum space in the uterus. Uterus is expanded so much to accommodate a 3 to 4 kg baby. So the baby takes the crouching position or the universal flexion position. And the left occipital anterior is the commonest position. This is where the back of the neck is also head also is called the occiput. So that will become the leading part. So throughout the pregnancy, the baby is in different positions. It will keep moving like this. But once the baby becomes big, by gravity, the head comes down. So once the head comes down, the most common position is the left side head down, and it enters the pelvis. Then it is called the engagement of the head, or the baby head fixing in common terms. So the pelvis is like that. So once it enters, it generally happens around 38 weeks in preemies, and during the labor in the second gravidas or the multiparas. So once the head enters, once with the pain happening, so the uterus will come gradually push the baby down, and the cervix dilates. The cervix, which is closed throughout the pregnancy, it dilates, and then with the pelvis gradually it comes down, it engages, it comes down, turns, and then it comes out like this with the nape of the neck as a hook. The head sweeps. I can show in this better. So with this comes down. This is the fetal skull. So once the nape of the neck is seen, the baby's head sweeps like this. First the head is delivered and the shoulders are delivered, and then automatically the breech or the legs comes out. And once that is when the baby comes out, gets exposed to the outside environment and starts crying immediately. That's called the vaginal birth or the normal delivery. Now, once the body decides delivery pains, and then you start getting pains, and then you go to the doctor. So, as I told you, once your doctor examines your abdomen, she can make out whether the uterus is contracting or not, whether the head is fixed, whether the head is down, fixed, what is the heartbeat, all these positions, whether it is a left side position, right side position, all these things can be made out by the abdominal examination. Then we talk something about an internal or a pervaginal examination. I am just going to explain to you what exactly we do in the pervaginal examination. So this cervix is always closed during pregnancy. The length is around 2.5 to 4 centimeters. It is always closed, and the one with the chemicals, different prostaglandins acting, the cervix gradually opens, and then the mucus flux comes out. Once we do our internal checkup or a PV checkup, what are we going to do? We use a sterile gloves, and then we explain the procedure to the patient, that we are going to insert our 2 fingers to make out the position of the cervix, whether it is dilated, whether it is open, how many centimeters it is open, and then what is the head, whether it is a head which is the leading part. And we actually palpate the suture line. See, this is an actual fetal skull. We palpate the suture line so that we can make out whether it is fully flexed or partially flexed, or whether it is a face presentation. Very rarely I told you face presentation. The baby's face will be presenting first, where we can feel the nose and the soft parts, we call this. So with that internal examination, we can make out all these information. So when the baby's head, when the cervix is closed, when we do our internal examination using gloves, when we put our fingers, with the woman lying down with the legs flexed, we put our finger, we insert our fingers. This is a normal cervix, which is long, that's around 2.5 to 3 centimeters long, and it is tightly closed. So we can make out, we call it as cervix unfazed os closed. So you can hear the doctors discussing among themselves, what is the dilatation, is the cervix closed or open, all those things. So this is what we are looking at, the normal length of the cervix. So it is still intact, it is long, and it is closed. This is how the cervix is during the pregnancy and also during early labor. Once the cervix starts becoming it's opening slowly, then that is how it will feel like, and that is how it will look like. So once we insert the fingers, we can make out whether the cervix is 2 centimeter, and once it gradually opens, it becomes 4 centimeter, then it becomes 5 centimeter. And once the cervix is fully dilated, so when I put a hand, I can make out the suture line, whether it is a head or the breech, face, all these things we can make out. And if it is a head, I'll know the position. I also know how many centimeters it is dilated. But the baby's head or the biparatal diameter, or the largest diameter, is 9.5 centimeters. In an average sized baby, give me the skull bone. Yeah. This is the largest diameter. Can you see that this is the largest diameter of the skull? This is the biparatal diameter. So this is around 9.5 centimeters. So naturally the cervix has to open that much. So the full dilatation is called the 10 centimeters. So when the doctor keeps checking you every 4 hours, once you get admitted and once you are in labor, the doctor keeps checking you are doing a PV once in 3 to 4 hours, depending on your pain, to examine how many centimeters it is dilated, whether the head is in the higher position or whether it is coming down. So you can see, you can hear the nurses and the doctor discussing what's zero station, -1, -2, +1, plus station. Now this is how it will look. So now this is the pelvis. So in the pelvis, the baby's head is coming down. So initially it was all closed and then it is coming down and then it starts opening up. I'm going to do an internal check like this. So that is when I can make out so many centimeters it is dilated. And also I can make out, compared to there are two bony prominences called ischial spines. That station is arbitrarily called as a zero station. So I will know if the head is above that, it is -1, -2, -3. If the head comes below that, then I will know she is +1, +2, +3. So once the cervix is fully dilated, the head comes out, leaving the cervix behind, the head comes out as a normal labor. This is how the normal labor happens. This is why we do a cervical examination. So this normal labor is divided into 3 stages: first stage, second stage and third stage. First stage is from the onset of the labor pains till the cervix dilates fully, that is up to 10 centimeter. Second stage is from the full dilatation to the delivery of the baby. Third stage is delivery of the placenta and the membranes. Fourth stage is additional monitoring of the mother after the placental delivery. So this first stage, this is the longest stage where your brain decides to start the labor pains, and then you start getting lower abdominal pain or back pain, and then you discharge a bloody mucus plug, and you go to the doctor, then you get admitted. You could be open 1 centimeter or 2 centimeter. I told you how we do a per-vaginal examination and then see what is the status of the cervical canal, whether it is open and whether the head is down, and what is the station, whether it is above the spine or below the spine. And generally we don't hurry the process of labor. So if everything is normal, that is if the mother's BP, pulse rate, hydration, if everything is normal, and also the baby's heartbeat is good, we generally don't try to hurry any stage of labor. Okay, so then we have to leave it as natural as possible. So this first stage, which is from the onset of labor pains to the full dilatation, can go up to many hours in a pregnant woman. Particularly in the first timer, there is a first pregnancy. That is, again, the first stage is divided into 2 stages: latent phase and active phase. Latent is from 0 to 5 centimeters. This 0 to 5 centimeters can take 1 or 2 days also. Okay, so you go to the hospital, you are 2 centimeter, and again for that to dilate up to 5 centimeters, it may take long time. It may take early in few people, and multiple deliveries. There is more than 1, 2, 3, 4 deliveries. It becomes very fast. And once it becomes the active phase of first stage, that's around 5 centimeters to 10 centimeters, is little faster compared to the latent phase. So during the latent phase, now you go get admitted to the hospital with labor pains, and then the doctor examines and everything is all right, baby is good, and then you are in early labor. We generally encourage you to take the position of your rest or activity or walking. You can do prenatal exercises, you can do labor positions, you can try out whatever you are taught in the labor class, you can try out, or you can simply lie in bed, whatever is comfortable to you, you can do it. And some women can like massages to the back or body massage, take a warm bath, listen to some good music, have a soft diet or drink lots of juices or liquids, so all to keep you hydrated. So this is how we take care during the latent phase or the initial phases of labor. And once you get into active stage of labor, where you start getting contractions faster and the cervix is dilating faster, you may not be in a mood for all these relaxation or massages because you are having so much of pain. That is when you can ask for a painkiller or an analgesic with the doctor. There are different methods of analgesia. One thing is physical methods, where you can take a back massage, And physiotherapy, there is something called a TENS machine where they give very small electrical impulses so that your brain is distracted from the labor pain and focuses on this. And then there can be something called a epidural analgesia where the anesthetist takes you to the OT and gives an injection to your back, puts a very small catheter to your epidural space, and he can give you some analgesic injections there. That will reduce your pain by 80 to 90%. But at the same time, you can move your legs, and you can't walk though. You can move your legs and you can roll around in the bed. That is epidural analgesia. You see, there are plus and minuses of this analgesia. One thing is you are very comfortable without pain, and then you tend to lie down and relax. So the natural urge to push or natural urge to deliver fast will come down because you are not appreciating the pain. So in epidural analgesia patients, the delivery can be prolonged, okay, because they don't have the natural urge to push. You require a lot. Either one thing, you require the abdominal muscle strength with the uterus contraction, both of that, to push the baby out of the birth canal in the second stage of labor. Because you are not perceiving the pain, your abdominal muscles do not contract so much. It is just the uterus contracting. So that is when the baby can come down up to an extent, but then beyond that you are not pushing at all. So that is when we have to use a vacuum delivery or instrumental delivery called forceps or a vacuum, because we can't keep the baby stuck there for a long time. That shouldn't be causing any distress to the baby. So there are both advantages and disadvantages of labor analgesia. But I feel in my practice I have seen lots of women, thousands of women who are strong enough to not take any injections or any analgesia, but then just go on their positive mindset and good health and good physical activity during pregnancy makes it very easy for them to tolerate the pain, and then they can deliver faster compared to women who do not have adequate health or not good physical activity, obese women, and they are the ones who can ask for analgesia and then can go for a prolonged labor and in turn instrumental delivery like vacuum or a forceps delivery. So in the first stage of labor, it is from the onset of contractions to the full dilatation. First phase is latent phase, 0 to 5 centimeter, active phase 5 to 10 centimeter. So once some girls can have a vomiting during the pain, because once the cervix is dilating, it can cause vomiting. So we don't allow solid food, we allow only liquids. You can have tender coconut soups and buttermilk and fruit juices or milk, and you can take light food. And then otherwise, if you're not tolerating any liquid at all, we give IV fluids, because we want the mother to be hydrated, we want her blood pressure to maintain, we want her pulse rate to be normal. So we give IV fluids in case if you're not tolerating the oral liquids. And we don't allow solid foods, because sometimes in case if there is any problem in between and then we go for a cesarean section, we don't want the stomach to be full with solid food, because they can vomit and aspirate to the lungs. That is called aspiration pneumonia. That can be risky. So that is why we tend to keep the stomachs empty or relatively empty, or give only fluids during the active phase of labor. Now, when do we stop? When do we say that this active phase is prolonged and the woman is suffering too much? When there is a maternal exhaustion, when the pulse rate becomes very high, when the BP falls down and the patient is restless and when she can't take the pain anymore, or whenever there is a fetal distress, that is when we reassess. Now, should we go intervene or do something? Should we add any drips to the pain exaggerating or pain enhancing medications to the drip? We decide. So in the active phase, generally in the first timers, up to 10 hours we can wait. That is from 5 centimeter to 10 centimeters, we can wait up to 10 hours. In a multi or a second, third delivery, we can wait up to 8 hours. Generally, it does not take so much. It happens way before that. If it is, if the cervical dilation is stuck at 6 centimeter or 7 centimeter or 3 centimeters for many hours together, then we think there is something called a cervical dystocia. We can't tire the woman or the baby much more. That is when we intervene and go for a cesarean section. So when we are monitoring you, when the doctors, the gynecologists, the resident doctors, when there is labor room staff or the midwives we call, and housekeeping staff. All this, there are a lot of women around you, and we also encourage one of your family members to be with you throughout the delivery process, so that you feel safe and you get reassurance from your family member. So when with so many people monitoring you, and we have to monitor the baby also, it's not only you. So we check the baby's heartbeat every 1 hour, every half an hour to 1 hour in the latent phase, and in the active phase every half an hour we check. And in the second stage of labor, once it is fully dilated till the delivery, we check after every contraction in high risk patients. In a low risk woman, we check every 5 minutes. Sometimes we continuously monitor the baby's heartbeat, because we don't want the baby's heartbeat to go very high or very low. The normal baby's heartbeat is around 120 to 160 beats per minute. Generally, during a contraction, the heartbeat tends to come down, but immediately it picks up. Whereas in case of a fetal distress or acidosis, if the baby is not doing well inside, the baby's heartbeat can come down persistently to 100, 80, 90. That is when we know the baby is not happy inside, and try to accelerate the labor or use an instrumental delivery or go for a cesarean depending on the stage of labor. And also the baby's heartbeat, if it is more than 160, it goes to 180, 200, that is called fetal tachycardia. That also is not good for the baby. This baby can be having any hypoxia, or that is less oxygen blood supply to the baby. That is when again we have to intervene. So in the first stage of labor, we keep you in the ward initially, and later shift you to the labor room with a lot of doctors and the support staff monitoring you, and with your family member at your side reassuring you. We give you oral fluids, we encourage ambulation, we ask you to walk, or if you are tired you can lie down. We give you oral fluids, we give IV fluids, and intervene to enhance the labor pains if there is any problem. Otherwise we let it go as natural as possible. That is till the full dilatation. So the second stage, or the full dilatation, that is the action phase, where you are getting very good pains. The baby's head has come down, and also the cervix is fully dilated. The door is fully open. Now the uterus has to push the baby so that it comes out easily. So that is where the lie or the baby's head, if the baby's head is too big, it can't come out. That is called cephalopelvic disproportion. Then again the head gets stuck, and then you can't deliver normally. And also if the baby position is different, if there is a bro presentation, if the baby's bro is presenting part, again the diameters are too big, because the pelvis does not accommodate that baby's head. That is when again the delivery can be problematic. And also if there is any oblique lie, sometimes we feel the baby's head is kind of fixed, and suddenly it goes up and turns sideways, then the shoulder can come out. So these are all the things which can happen at the time of delivery. So that is when constant monitoring. Every 4 hours, every 3 to 4 hours, we do a pervaginal examination to see the status of the cervix, and also whether the head is coming down or in the same position. The head is in the same position. Generally it comes 1 centimeter per hour in the second stage, so it has to keep coming down. If it is stuck at the same place, almost she is getting very good contraction and she is pushing, the head is not coming down, that means there could be some problem with the size or the shape of the head, which is not allowing it to glide through the pelvis. So that is when we reassess the pelvis, and then we intervene. We have to do a cesarean, because we can't leave her eternally in labor, because she gets exhausted. There is so much of energy going to the contractions. So the mother can have ketosis, the mother can have dehydration, tachycardia, more prone for infections, and also heavy bleeding after delivery. So this is the second stage. Active management of second stage is that we encourage you get that once the baby's head is pushing down. So give me the pelvis, yeah. So once the baby's head, so now the baby is going inside, it is almost pushing down. Behind the vagina is the rectum or the anal canal, where the stools are stored. So like you get that sensation that you're going to pass motions. So like how you feel when you want to pass motions, that urge is there. That urgency is there, means the baby's head has come down very well. We encourage you to push like that. How you pass motions, hard motions like that. Clench your fist, hold your thighs, and push your best during the contractions. So all of us will be around you to support during the pushing phase. And once there is no pain, we ask you to totally relax. So once the baby's head, once the baby's head is seen, now this is the pelvis with the mother lying down. So once the baby's head is seen, we can see the whole head. Imagine that these are the thighs of the mother. Once the baby's head is seen, then the natural introitus, it has to stretch almost up to 10 centimeter. If the introitus or the perineum is, the skin is very tight, it may tear, coming out like this. The baby may tear the area, and then that also the rectum or the anal canal, which is right behind your introitus or the vagina, it may also get torn. So that is when we give a deliberate cut called episiotomy. I'll be adding few pictures for that. So episiotomy or suture, people will call, did you give me suture? How many sutures did you give? So all these questions are asked to us. So this the vulva or the opening of the vagina is there, we give a cut, we give a local anesthetic, we use the scissor and give a cut, so that there is a lot of room for the baby's head to come out. Okay, if the baby's head is too big and if the vagina is too rigid, it may tear the surrounding organs and also damage the rectum, they calling perineal tear. So we give this suture, the baby's head comes out. Once the baby's head comes out, we pull the baby out, then we deliver the shoulders, the posterior shoulder first and the anterior shoulder, and the breech and the legs automatically fall down because they are soft organs. And once the baby head comes out, then we put the baby on the mother's abdomen, that is called skin to skin contact. So okay, so it is very interesting. We clean the skin before we are definitely we're going to make the area clean. And once the baby is born, we put the baby on the mother's abdomen. So there is a skin to skin contact, very emotionally, very strong emotions to the mother. So whatever pain she went through, she will immediately forget that. And also the baby, by natural reflex, there is something called a crawling of the baby. So it will crawl towards the breast. The baby, without even the umbilical cord getting cut, it will crawl towards the breast. That is a natural instinct of the baby to have the breastfeed. So once the baby is born, we immediately clean the baby, because it is from a very warm environment, it has come out to a very cold environment. Okay, so we rub the baby's back, we rub the baby's scalp with a sterile towel, keep it warm, put on the abdomen, so that we let the mother to touch the baby, feel the baby. That's a very emotionally strong moment for all of us to witness. And that is why I feel, being a busy obstetrician, I still enjoy doing the deliveries, because I get to witness the nature's wonder, how each woman welcomes her newborn to the world, how a new life is created. It's so wonderful to be part of that journey and part of that moment. So how much ever strainful, how much ever midnight deliveries I take, I still enjoy that. That is why I have not given up my obstetric practice even after 25 years. So once the baby is born, we rub the baby, keep it warm, and then we let the mother to hold the baby. And there is something called a delayed cord clamping. So initially, years before, we used to immediately cut the clamp and separate the mother and the baby and give the baby to the pediatrician. But now the concepts are changing. There's something called a delayed cord clamping, where we wait for a minute, full minute, for the pulsations to stop, so that let the baby get maximum amount of blood before the placenta separates, and that advantage we give to the baby. That's called delayed cord clamping. Of course, there are some conditions where we can't do it. That is when the baby is distressed, when the baby is not crying, when there is heavy bleeding and all those things. In such situations, immediately we clamp the baby and give to the pediatrician. So after the delayed, after 1 full minute, we cut the cord, and then give it, hand over the baby to the pediatrician. The pediatrician, with his team or with her team, they will take the baby, keep the baby warm again, clean the baby, check the baby's oxygenation, pulse rate, auscultate the baby, see how healthy the baby is, and later, once the baby settles down, they check the baby's external organs and see if there's any defect or something. Then they suck the baby has swallowed any meconium, they do the suction. And then that is when also immediately they administer an injection called vitamin K, which is very important for the baby's blood coagulation system. So this is the role of pediatrician and his team during a normal labor. So once the baby is born, and once the mother is very happy and overjoyed, and we give the baby, so the mother is looking at the baby. She is no more with us. She doesn't really care what we are doing. She is already turning her face and looking at the baby and the warmer. That is when our most important aspect or the stage of pregnancy or normal delivery happens. That is the third stage. Third stage is the delivery of the placenta and the membranes. Now you can see that this is the placenta. Placenta is the organ. It's a very vascular, thick organ, which is attached to the, connected to the uterus, inner layer of the uterus. And there is an umbilical cord which is coming out and attaching to the umbilicus or the navel of the baby. The third stage of labor is the most important stage of labor, underrated because all the focus shifts with the baby. So everyone is happy. The family which is outside are also very happy, and the mother is happy, and she is actually looking at the baby, which is being attended by the pediatrician and his team. But then we doctors who are at the bottom end, we are very very worried about the third stage. The third stage is the delivery of the placenta and the membranes. Placenta is the organ which is connected with the uterus muscle, inner surface of the muscle. So this is the very vascular thick organ. It is like it's a circular organ with lot of vascularity. There are a lot of blood vessels. It's a very beautifully designed organ by the nature. So this will take all the blood with the nutrients, with oxygen to the baby, filter out all the toxic content and give a good nutrient and oxygen to the baby throughout the pregnancy. So once the baby is delivered, the baby cries out. Once the baby comes out, it is getting exposed to the external cold environment. The blood vessels which is in the cord will get constricted. It's called a vasoconstriction. So once it gets constricted, it will no longer receive the blood from the placenta. So maximum up to 1 minute it will receive. After that, the placental pulsations, the umbilical cord pulsations will stop. So once it stops, the baby has to cry independently. It has to get oxygen from the air to the brain. So that is why the baby crying immediately after a delivery is extremely important. If the baby does not cry, we can't just leave it alone like that, because the baby needs oxygen for the brain and for all the organs of the body. So immediately, in cases of a fetal distress and baby does not crying in spite of coming out and basic rubbing and warming, keeping the baby warm, then the pediatric team will give resuscitation to the baby. It will give oxygen in the form of a mask, or sometimes they may have to give a intubation and put the baby on a oxygen flow. So that comes as a part of neonatal resuscitation, we call it. So that is that the placenta it is the actual mother of the baby, because it gives food and oxygen throughout the pregnancy. Once the baby is delivered, the uterus, such a big uterus, will start slowly shrinking. That nature has designed so beautifully that it will gradually shrink and come to this big size. So such a big uterus will gradually shrink down to this with the placenta. Once it shrinks down, the placenta, whatever the blood vessels, the blood vessels are very big. It is as big as our thumb size. Such big sinuses. There is a beautiful flow of the blood freely to the placenta. The normal blood flow to the uterus, non-pregnant uterus, is around 60 ml per minute, whereas in a pregnancy it will be 600 ml per minute. So 10 times the blood flow to the uterus is more during pregnancy. So this blood flow has to be cut off suddenly. So there is a uterus which is getting contracted. Once it is contracted, all the blood vessels will be collapsed. Once it collapses, the placenta separates. The placenta separates and it has to come out. So the woman who, after delivering a baby and feeling happy, boy, girl, healthy, pink, all that, and then suddenly she starts getting more pains. A pain similar to a delivery pain, because now the uterus is contracting and trying to push the placenta out. Once the placenta and the membrane comes out, that is when the uterus is kept contracting by different chemicals which are released in our body. And also in this stage, we don't want the woman to lose blood. So we give a lot of uterotonics. The injections are called uterotonics. Oxytocin or a syntocin on drip, we give in the form of a drip or an intramuscular injection. And in a woman, suppose the uterus does not contract, if the baby is too big or if the placenta doesn't come out, then we give prostaglandins also, so that we want the uterus to be contracted. Very, very important, because if the uterus becomes flabby and it opens up, all the blood vessels open up, and there can be a lot of blood flow. It is called a postpartum hemorrhage. The normal blood loss in a normal delivery is around less than 500. It's around 350 ml, and during a cesarean it's around 500 ml. Any blood loss beyond 500 ml in a normal delivery, any blood loss more than 1 liter in a cesarean section. Of course, we can't measure, what is a blood loss. We will know when the blood is flowing very fast and when we are using a lot of mops or the gauzes. So that is when we know that the blood loss is more than usual. And also immediately the mother's pulse will start increasing. Mother's BP will start to falling down. We call that as a hypotension or low BP. That is when it becomes serious. So the placenta and the membranes coming out is very crucial. We can wait up to 30 minutes if there is no active bleeding. We wait generally up to 30 minutes. We give these uterotonic injections like oxytocin and prostaglandin injections and prostaglandin tablets so that the uterus contracts and pushes out the placenta. It is a very crucial time of the delivery. So once the placenta and the membranes are expelled, we still watch the woman for next 1 hour. Every 10 minutes we are going to check her BP and pulse, and per abdomen we are going to massage the uterus and see if there's any clots. Postpartum hemorrhage, as I was telling, that is excessive bleeding after a delivery, is the leading cause of mothers dying all over the world. Okay, particularly in India, lot of women dying during the time of delivery. The leading cause is postpartum hemorrhage or hemorrhage or the heavy bleeding which happens after delivery. So ways to prevent that is that making sure that you are not anemic, your hemoglobin is more than 12 grams throughout the pregnancy and at the time of delivery. And also the doctors have to be very alert to anticipate the postpartum heavy bleeding and give you adequate medications and intervene accordingly so that you don't end up having a very serious situations. So the third stage is the delivery of the placenta and the membranes. We generally wait up to 30 minutes, and even we can wait up to 1 hour if there is no heavy bleeding. If there is a heavy bleeding, we do something called a manual removal of placenta. We put our hand inside the uterine cavity and separate manually to pull it out. That is done under general anesthesia. It is not done very often. It happens whenever the placenta is not separated well. So that's called manual removal of placenta. The fourth stage of labor is the final stage of labor, which is again the most important stage of labor, which we should not neglect at all. Here, by this time, once the baby is delivered, the pediatrician sees the baby and examines the baby, and we do the delivery of the placenta and the membranes. After that, if there is a episiotomy or a suturing, we give local anesthetic and we repair, we put it back to its original shape. So we repair in layers the suture or the episiotomy. And once that is done, we check for the bleeding, and then that will take around 15-20 minutes. That is when we bring the baby to the mother and start the breastfeeding. So the breastfeeding has to be started within 1 hour. It is called a golden hour. It's extremely important for the baby to feed within the first hour of birth, so that it gets all the nutrients from the colostrum or the first secretion of the breast, and also it will increase the bonding, it will keep the baby warm, and this is known to increase the IQ of the babies later. So we encourage skin to skin contact. We do always follow the practice of delayed cord clamping and the golden hour breastfeeding or breastfeeding within 1 hour of birth. So in the fourth stage, once the mother is cleaned, she has fed the baby and now she's happy and relaxed and relieved, we have to keep a watch on her. So we check her blood pressure and the BP every 15 minutes, and we press the abdomen where the contracted uterus is felt like a very hard ball. A lot of women tell that my tummy is not reduced and there is still I can feel something very hard, that is the uterus which is contracted. And then we check for the bleeding every 15 minutes after 1 full hour of the after the labor. That is when we encourage the woman to pass urine, because during all this second stage and third stage and the fourth stage, the women may not have emptied the bladder, and because of the fluids there could be a urination. So we encourage her to pass the urine and then shift her to the ward. So this is a journey of different stages of labor, where we, from the initiation of the contractions and when you have to get admitted, and why the doctor does a PV examination, why they keep checking your abdomen, why they keep checking your baby's heartbeat, and then what exactly happens during delivery, why episiotomy is given, what are the choices of analgesia or less painful delivery, and what are the effects and side effects of different types of analgesia, and why placenta and delivery is extremely important, and why you should not bleed more during delivery, because that can cause a lot of effect on your health, general health, and also can cause mortality. That is the leading cause of mortality, postpartum hemorrhage, and how we doctors and the team take all these precautions to avoid any complications throughout the different stages of labor. The baby is there within the uterus in a bag of membranes. So there is a membrane. Imagine a balloon filled with water and the baby is floating in it freely with the placenta attached to the uterine muscle or the myometrium, and then there is a umbilical cord which is connecting the baby. So why do we need this water around the baby? So that the baby can move freely within the uterine cavity or within the pregnancy sac. And then also there is a cushioning effect and also insulating effect. Suppose if there is a change in position or if there is a bump, the baby should not go hit the wall. So there is a natural cushioning effect by the water around the baby. Now this water is called amniotic fluid or liquor. It's also called liquor around the baby. So there is lot of water. There is lot of water around the baby in the initial stages of pregnancy. And once the baby becomes bigger and bigger towards the term or towards the labor, the water around the baby is just adequate for the baby to keep insulated or cushioned. Okay. Now when the cervix is opening, when the patient enters the active phase of labor, 4-5 centimeters, this bag of membranes can rupture spontaneously, so that the water gushes out. This water is generally like a tender coconut. It is like a little straw colored with little whitish flakes, that is a skin flakes. It's called vernix. So that is and it is sterile. It is not infective. It is sterile. So once the water breaks, the baby's head can come down and sit more perfectly fitting to the pelvis. So sometimes in very high risk pregnancies, whenever there is a fetal heartbeat variation, we go intervene and do a rupture of membrane. So what we do is we use our fingers. There is something called an amnio hook. We tear the membrane so that the water comes out. Now this water coming out, it can accelerate the labor, make the labor faster. And also in a rare situation called meconium aspiration or meconium stained amniotic fluid, where meconium means it is a greenish liquid, or the baby's liver produces bile. Okay, so this bile is secreted to the baby's gut along with the swallowed water and little bit of hairy content and all that. There is a meconium or a thick green tar like liquid. If you notice the babies when they are newborn, the motion is not yellow in color. It is just a green, very thick. It's like a mehendi, very thick green. Green in color. It is there in the baby's gut or the rectum or the anal cavity. So whenever there is a distress of the baby, suppose now when we are anxious or when we are distressed, like the sympathetic activity is stimulated. Suppose you want to go on the stage and give a talk or something, then you start sweating and then you start trembling, your heartbeat increases, and sometimes you feel like passing motions or going to the toilet, right? So that is how whenever the baby is distressed for any reason, the baby can pass off the motions within the uterine cavity. Okay, so then the uterine cavity, that water liquor becomes greenish in color. So as I told you, the liquor normally it is straw colored or it is colorless. In a meconium aspirate, in the meconium stained amniotic fluid, in some cases of distress, the baby may pass off the fluid before only within the uterine cavity. So when we rupture the membranes or when the baby's membranes rupture, we can make out a green liquid coming out. That is called meconium stained amniotic fluid. What does it mean? It means that baby has been distressed and it has passed off the motions. That is one. Second thing, with the very thick meconium, suppose the woman is only 2 centimeters or 3 centimeters or just one finger loose and there is already a thick meconium, that means that this baby has to swallow that water till the baby delivers or comes out. That is more than 10, 12, 14 hours. That can be risky to the baby, because when the baby is swallowing that greenish colored liquid, it can aspirate to the lungs also. It is called a meconium aspiration syndrome, where the green liquid goes to the lungs. We can't pull out anything from the lungs. If we swallow something, we can put a Ryle's tube and give a stomach wash, whereas whatever goes into the lungs, we can't pull out that, or we can't aspirate that liquid back to the system. So that can be a little risky situation where the baby's lungs are filled with this green water. It can cause something called a chemical pneumonitis, and it can cause problem in the breathing of the baby. So if the doctor says, they rupture the membranes and the baby's, the liquid is very thick green, and because you are just 2 centimeters, we may have to do a cesarean because this baby may drink that water. People will tell dirty water, that is not dirty actually, it is a meconium. So in such cases, we may have to do a cesarean. Suppose if she is already 7-8 centimeter and there is a greenish water or the meconium, then we hasten the delivery by giving syntocinon drip. We use the instrumental delivery like vacuum or forceps and pull out the baby faster, so that the baby is not drinking that or aspirating that to the lungs, causing a very serious situation called meconium aspiration syndrome. See, these babies who are exposed to this greenish liquid or a meconium may have difficulty in breathing once they are born, and they may need a NICU care. they may need a ventilator, and it will gradually go off in weeks. They may need NICU for weeks together. So this is something about the liquor or the water around the baby. Sometimes when we rupture the membranes or when there is a spontaneous rupture of the membranes, there can be bleeding or a blood stained water. That is still more risky. That means that the placenta has separated, which is very, very risky, which can cause a lot of distress and can cause death of the baby also. So if there is a bleeding within the amniotic cavity, that is very risky. Immediately we have to deliver. We have to hasten the delivery. If she is nearing the normal delivery, we deliver normally. Or if she is just 1 or 2 fingers and there is bleeding within the uterus, we will do a cesarean. It's called abruptio placenta. And then a thick green liquid is called meconium aspirate, meconium fluid. Again we deliver faster. We don't want the baby to get exposed to that. So clear liquid means normal. We can water out the baby once it is leaked. That will actually enhance and make the delivery faster.
Hello, doctor.
with Dr. Chandrika Anand.